next talk, which is on phacoemulsification in eyes with corneal opacities by Dr. Aneeta Jabbar. She is a senior cornea, phaco, and refractive surgeon working in Little Flower Hospital, Angamali, and Eye Vision Eye Care Center, Chalakudi. She has won many awards to her credit, like Professor Sankara Menon Award, Tony Fernandez Best Video Award, and Professor S. Sivareddy Award, etc. Over to you, madam.
Good morning, and thank you, Kalai, for this introduction and for the opportunity. And I'm sorry for my bad throat. I'm having a severe infection. That's why. Good morning. And let's start by understanding what makes these cases so challenging. So we all know that performing phacoemulsification is a joy when the red reflex is bright and the capsule shines clearly. But imagine the same surgery when the cornea is hazy, the reflex is dull, and every move feels like operating through fog. That is the challenge we face in eyes with corneal opacities, where visualization, precision, and judgment all have to work at their best. So today I would like to share how we can safely perform phacoemulsification in such eyes. I'll be talking about the preoperative planning, small intraoperative modifications, and the realistic expectations you should give to the patient that can turn a potentially risky surgery into a rewarding outcome for both the surgeon and the patient. So here you can see a peripheral corneal opacity, corneal adherent leucoma, where the iris was adherent to the full thickness scar. But here I have performed a toric implantation, and the outcome was rewarding. Thus, corneal opacity obscures the surgical view and increases the difficulty. Here in this video, you can see that there is a peripheral scar, but in between the scar and the limbus, there was a normal limbus, so that you can precisely make your incision over there. The common causes of the corneal opacity being the trauma, infection due to any causes, the dystrophies and degenerations. Also, you have to do a phaco or a cataract surgeries, and also in post-surgical scars. And the goal in all these cases should be aimed for a safe cataract extraction with maximal visual gain. So the preoperative evaluation is also important. Assess the location, density of the scar with your anterior segment OCT, and the depth of the opacity. Like it might be a central opacity, or it might be a paracentral scarring, like what you have seen in the previous video. If it is a paracentral opacity, you can safely perform your surgery. And if it is, there are more challenging cases, challenging situations, then better to, I usually nowadays do it under subtenon anesthesia rather than topical. And if it is a non-dilating pupil, and if the view is hazy and all. And you can assess the health of the endothelium with a specular microscopy, and also a pachymetry to assess the endothelium. So here in this video, there is a post-surgery, post-pterygium peripheral scar, and you can avoid the scar and put your incision beyond the scar area and assess for any thinned area and all with a preoperative ASOCT, and then plan your incisions there. And IOL calculation also sometimes it will be difficult in a scarred cornea. And in that cases, either there are various methods like using the fellow eye K1, K2 values, or the topography, or the other methods like EKR readings and all. And patient counseling is also very important, and to give them the realistic expectations. Explain to them that we are dealing only with a cataract, but the corneal scar will remain. If there is peripheral scarring and all, there is no need of combining with a keratoplasty and all. Even phacoemulsification will give adequate vision to the patient. And biometry also, as I was telling, that can lead to unreliable values. You can use the other eye K readings or the topography, the mean values you can take and aim for a slightly myopic refraction to avoid postoperative hyperopia. Here also there is a minimal scarring. There are only peripheral opacities, but here also I am preferring subtenon anesthesia, and the phaco was performed in the usual manner. And if the view is hazy, you can use a trypan blue for before your capsulorhexis. So the surgical intraoperative challenges can be a poor visualization of the capsule and the red reflex. If you don't have the retroillumination, very good retroillumination, the microscope also will vary in different OTs and all. Then you will have to deal with the irregular astigmatism postoperatively also. Sometimes the patients will have compromised endothelium, so you have to use agents like Viscot and all. And sometimes there will be danger for the capsulorhexis extension or the posterior capsule towards the equator and the posterior capsule rupture risk, because there is poor visualization. And this is a case of Stevens-Johnson syndrome. The other cornea was comparatively worse than this eye. So she was not having useful vision even with scleral lenses. So I took for cataract phaco for the better eye, the eye with a better cornea. But luckily the microscope had given me a good retro view, and even in spite of the very poor cornea vascularization and the opacities and all, phaco could be performed relatively better, and the patient is having good vision now. Only thing, they have to withdraw the contact lenses, scleral contact lenses for a week or so. The patient was finding it very difficult without the sclerals because of the lid margin keratinization, which recurred again in spite of a mucous membrane grafting of the eyelid. So these are the surgical challenges. And the visualization aids, as I was showing, trypan blue staining of the capsule will be very useful. You can use either an endo illuminator or the oblique. You can tilt the microscope till you get the red glow. But if you are using the Lumira eye and all, there is no need for the. You will get a good red reflex. So this is a case of that peripheral scar where there was a small anterior seneca here, but the patient opted for a toric lens, and the surgery went on well because the central cornea was comparatively giving a good view. And if the cornea is getting drier and drier, you can use viscoelastic coating to get a smooth corneal surface, and frequent irrigation to maintain the clear corneal zone. Avoid excessive light exposure to prevent the glare, because the scar itself will reflect so much light, and the glare will be more. So this is the toric marker, and finally the patient had got good result. So surgical modifications you can think as, if you feel like the rhexis will run out and all, you can aim for a small rhexis, either 4.5 or 5 for well control, and low fluidics and phaco energy. Either you can do a divide and conquer or the direct chop method. And in this case, it was a poorly dilated pupil. So I have, this is a post-traumatic scar. This is a very subtle scar, but I have kept a 3-piece IOL because in traumatic cataract, you don't know the zonular support and the capsule support and all. And convert into manual SICS if the visualization is inadequate. So, but cases like this, look at this cornea, cases like this, you need a combined keratoplasty, triple procedure or a sequential keratoplasty because of and because there is no view and there is no point in taking out the cataract alone, leaving this type of cornea. So the decision is based on the opacity size and the site and the surgical skill. To conclude, phacoemulsification in eyes with corneal opacities test not only your skill but our patience and judgment. With careful case selection, the right visualization aids, and gentle surgery technique, we can offer meaningful vision even through a cloudy cornea. So every clear postoperative cornea reminds us that clarity in surgery begins with clarity in planning. Thank you.
Thank you, ma'am, for that.